What's up, guys? This is a special populations assignment. My case specifically was autonomic dysreflexia. So what is AD? Autonomic dysreflexia is a condition of uncontrolled sympathetic responses secondary to a participant which generally occurs in patients with injury to the spinal cord at levels T6 or above. A brief description about it. It's been reported that 50 to 70% of patients with lesions at or above T6 will experience symptoms of AD. However, it should be noted that AD has been seen in patients with lesions lower than T6. A brief overview of this pathophysiology shows that most prominent component of AD episode is dramatic rise in blood pressure. Primarily, this is seen because of the aberrant or diverging away from normal sympathetic nervous system overactivity. With that being said, normal regulations of the sympathetic output from the spinal cord is modulated by input from the higher centers. If there's spinal cord injury, the input is lost. Spinal circuits are now responsible for sympathetic activity at or below the lesion level. So some signs and symptoms will have headache, hypertension. With SCI or spinal cord injury, it is noted that there's lower blood pressure, flushing the skin above level of injury, sweating above the injury, nasal congestion secondary to vasodilation, blurry vision, and increased spasms. It should also be noted that the precipitants of AD are genitourinary, gastrointestinal, and musculoskeletal. As for treatment, although AD is life-threatening, most patients will recognize initial symptoms. However, patients most near acute AD stages may be less aware, which is vitally important because early recognition is key. It's been suggested that patients with this disorder carry emergency medical cards to assist medical practitioners in the acute management of this condition. Initially, patients should be seated upright to produce an orthostatic decrease in blood pressure. Restrictive clothing should be removed, example, a belt, and blood pressure should be monitored. With that being done, the MD should begin to look forward and find the precipitant. Pharmacological treatments can be administered as well as other drugs that can be administered intravenously. And to wrap things up, autonomic dysreflexia is important clinical diagnosis that requires prompt treatment to avoid devastating complications. It is a clinician's responsibility to have the basic understanding of this pathophysiology. In the end, the simple steps required to treat it.